and comments from Dr. Piercey, and then we'll turn it over for Q&A. If you would like to ask a question, please raise your hand. You virtually raise your hand and I will call on you to unmute your microphone. Please keep your microphone muted unless you're called upon so that we can make sure that we limit any interference with others that are on the briefing this afternoon. With that, Dr. Piercey, I'll turn it over to you.
Thank you, Sarah. Good afternoon, everyone. I do have a couple of quick updates. Then I want to spend some time talking about the details of vaccine boosters, and then happy to take your questions. So from an update standpoint, on case trends and hospitalizations, I'm cautiously optimistic. They are moving in the right direction. We are starting to see either decreases or leveling off in all areas of the state. You know, it's not uniform across the state. And so sort of the same way that it ramped up a couple of months ago is the same pattern that it's following now. So we're seeing some pretty sustained decreases in the Memphis and Jackson markets, but we're just now starting to see leveling off or slowing down of the rate of rise in our East Tennessee markets. Specifically, the Knoxville market, Southeast Tennessee, Chattanooga, and the Upper Cumberland regions, as well as a little bit of in Northeast Tennessee, are still really feeling the crunch, although they're starting to get a little bit of relief compared to what they had a week or two ago. So we're watching that, but we're encouraged by that, and hope things continue moving in the right direction. One thing before I move off of trends that I want to remind you about, and it's actually a little different this time than it's been in the past, is the trend on deaths. So you may remember from previous surges, we typically see deaths peak about 2 or 3 weeks after the peak of cases. Well, we haven't quite seen that yet, or maybe we're still seeing a little bit of it, and there's a couple of reasons for that. One is just that delay in processing. We don't record the death until all of the documentation is verified and completed. But the other thing that's a little bit different with the Delta surge that's causing our death peak to come a little bit later is the average age of the patient. So you've heard me say many times, the average age is much lower with Delta. That's also where the higher numbers of our unvaccinated population are. People who are younger, patients who are younger, typically have longer lengths of stay in the ICU. And if they are going to pass away, it's often more delayed than with older people. And so because we have a younger population, sometimes instead of coming in about 13 or 15 days, if they are going to succumb to the disease, it is oftentimes much later than that. You can also see that reflected in our hospital lengths of stay. Younger people actually stay in the hospital longer because they can tolerate more aggressive treatment. So I say that to say we may or may not have seen the peak of deaths yet, but I don't want you to get thrown off that it's coming a lot later, because it is, but there's a good reason for that. The other update I want to give you is on monoclonal antibody. You know, we've spent pretty much all the month of September worried about our supply. And fortunately, fingers crossed, we have had enough supply throughout the month of September. And I think with our waning demand that we will continue to have adequate or maybe even a little bit extra supply. We have been able, and it's been a process because we've had to really shift and move things around, but we have been able to keep supply at all 220 providers. And we have also been able to keep sort of full lines of patients coming in and not had to use our prioritization criteria. So that's a good thing. I do expect that to continue. We're still ramping up on all of our data collection processes, but HHS has done what they've said and has continued to give us a weekly allocation of that drug. And so far, we have been able to meet the demand. I do expect that weekly allocation process to last at least through the fall, if not into the winter. But with this enhanced data collection that we're having on individual site utilization, we'll be able to get that a little more smoothly as the weeks go on. I want to talk about vaccine boosters because there's a lot of information and it can be very, very confusing. And I'm sure your readers and your viewers and your listeners are having trouble sorting through that. So I'm going to try to break it down for you, but I'm sure there'll be questions and I'm happy to answer those for you. So let's first start with, what are the baseline criteria for getting booster doses? So number one, you have to have had a Pfizer product. The only boosters that are approved right now are for Pfizer. So that's the number one. Number two, you have had to have both of your doses at least 6 months ago. And so when you think about, 6 months ago was early spring, March, April, that's about the time where most of the general population was becoming eligible. So there are probably a lot of Tennesseans that had the Pfizer product and that have had at least 6 months since their second dose. So those are the initial qualifying criteria. Then when you move from there, you move into two broad categories, the should and the may. So the should are the people who, yeah, you probably need a booster. You should do this if you fall into these categories. So that is every person age 65 plus. We know that older people are at higher risk for severe outcomes. And so everyone that met those initial criteria that I mentioned about Pfizer and 6 months, everyone 65 plus should have a booster. Likewise, anyone in a long-term care facility, whether that is assisted living or a nursing home, they also should have a booster shot. And then if you are ages 50 to 64 with a medical condition, you probably should also have a booster shot. So let's talk about what those qualifying medical conditions are. It's a really big and broad list. And unfortunately, most of us in Tennessee have one or more of these conditions. They're very common conditions. Things like obesity, hypertension or high blood pressure, COPD, some people call that emphysema, heart disease, diabetes. Those are very common conditions that if you are ages 50 to 64, the CDC says you should have a booster shot. Now let's switch to the may category. This is more of a permissive type category, and it says you should essentially judge for yourself. If you feel that you're at enhanced risk, then you may have a booster shot if you fall into one of these categories. That is, if you are ages 18 to 49 with one of those medical conditions, you may have a booster if you would like that. And then also anyone age 18 plus that is at increased risk of occupational exposure. That's going to be healthcare workers, those that are taking care of patients that are frequently presenting with COVID-19 or with COVID symptoms. That would be one very prime example of occupational risk. So that's a lot to digest. And it's even more complicated because it's only with the Pfizer product right now. And when you get a booster, you need that same product. That's not an absolute prohibition about mixing and matching, but it's best practice to have the same product for your booster as you did your first two shots. So let me give you a couple of other tidbits on boosters, and then we'll open it up for questions. So one question that I very commonly get when we talk about qualifying conditions and who qualifies for something, I always get the question, are you going to require documentation? Are you going to have to show proof of that? This is a self-attestation, which means if you tell us you have one of these medical conditions, we're going to give you the booster shot, because the burden on the paperwork and the documentation is not something that we're going to pursue or create an artificial barrier for. You will self-attest to these conditions when you present at that site. Secondly, I know a lot of people have loved ones in long-term care facilities, and they want those loved ones to get their vaccination very quickly. The same process that we used back in January and February for providing mass vaccination at long-term care facilities will be the same process that we use here. It's called the Federal Pharmacy Partnership, and it's essentially the two large pharmacy chains, CVS and Walgreens, having partnerships with local nursing homes to go in and give booster shots. So whoever gave them the first time are likely to be the same partners to give them the second time around. Something that's very, very important when we talk about boosters, and I have to remind myself of this, and I would like for you to remind your readers and viewers about this, which is we are not going to boost our way out of this pandemic. the single most effective way for us to end this pandemic is to get the unvaccinated vaccinated. So while we're talking about boosters and everybody wants to make sure they're as protected as they can be, our primary effort should still be getting those who are unvaccinated to get their first dose. A couple of other things to be watching for coming up in the next few weeks. I do anticipate that both Moderna and then eventually Johnson & Johnson will have their booster shots approved. That probably will follow the same pattern as it did initially, where Moderna will apply for their EUA in the next 3 or 4 weeks for the booster shot. Same thing with Johnson & Johnson. But probably the biggest news in vaccine development that's coming up, I would estimate in the next 30 days or so, I don't really have any good eyes on that, but it's probably just in the next few weeks, is the Pfizer approval for ages 5 to 11. This will be the first vaccine we have for any child under age 12. And so obviously those are our school age children. Recognize there will be a lot of interest in that. I do anticipate that coming out certainly in the next 4 to 6 weeks, but we'll keep you updated on that. So with that, Sarah, I'm happy to take questions.
Thank you. We will turn now to our questions. First up is Brett Kelman with the Tennessean. Brett, please unmute your microphone.
Good morning, everyone, or afternoon. Dr. Piercey, thank you for making time. 2 questions related to monoclonal antibodies. One, I was curious if you could give us a statistic, a number on what the allocation has been in recent weeks. And 2, it is obviously fantastic news that we do not have a shortage and have not had to prioritize. Is that because the allotment to the state was bigger than anticipated, or is it because the demand decreased basically exactly at the time when the federal caps kicked in, or is it a little bit of both?
Yeah, so I'll take that second one first. It is a little bit of both. So initially, our first 2 allocations were right around 7,700 or 7,600, the first 2 weeks that they allocated. That was significant and more than we expected to get. It wasn't anywhere close to kind of what we wanted, but it did meet the demand. And at the same time, demand actually went down because this allocation process changed right about the same time that we were topping over the peak. So the factors lined up in our favor, thankfully. And so this week, for your first question, this week's allocation is about 6,300. And whereas that's about 1,000 less than last week, the demand is also quite a bit less. And so we were able to supply all 220 providers and actually had a few doses left over that we sent out to some of our higher volume providers to give them a little cushion. So I'm, again, cautiously optimistic, but still keeping a really close eye on it.
Thank you.
Okay, next question is for Jane Roberts. Jane, please unmute your microphone.
Hi, Dr. Piercey. My question is about contact tracing and not any of the issues you spoke about today. Can you tell me about what percentage the state is reaching now and how that's going? We don't hear very much about it.
That's a great question, Jane. And I actually haven't gotten an update on our sort of, I call it the conversion rate. I don't know that that's the right term, but it's the one that we actually get in touch with and complete the whole process and sort of get them all the way through the process. Even pre-Delta surge, that number was much less than 50%. And what I'm hearing anecdotally, it's even lower now for a lot of different reasons. One is, do people answer their phone? And we have trouble with that. They know they're going to get called and have appropriate contact tracing, which is touch points daily or every other day. We have converted some of that to text messaging, which has helped with uptake. It's a lot more convenient to do that than to talk to somebody on the phone. So that's mitigated that a little bit. But the other thing that we deal with, and it's understandable, as compared to the beginning of the pandemic when people were very, very frightened and they wanted every drop of information that they could get, they're sort of much more comfortable with it now. And so they don't see as much of a need for contact tracing. But it is an important work. Now, a broader question, and you didn't ask about this, but something to be thinking about is, and this is a rhetorical question, when do we kind of stop contact tracing? When in the process of the pandemic or when it moves to more endemic, do we stop that altogether? You know, we don't do contact tracing with influenza. I suppose they used to decades ago, but at some point you stop doing that because people know what to do. They call their contacts when they know they've been in touch with them and exposed them. So those are broad, high-level discussions that we as an industry are having, not just here in this state, but sort of as public health professionals. When do we transition from contact tracing every single case to just working specific outbreaks and then letting individuals do it themselves? So it's a good question, Jane.
Thank you. Next question is to Amanda Chin with Fox 17. Amanda? Amanda?
In regard to the monoclonal antibody treatment, if there isn't a lack of supply in the state right now, do you still recommend providers follow those NIH guidelines to prioritize those who are most likely to be hospitalized with the virus? And my second question is, what do you say to those who are fully vaccinated who feel like they were kind of pushed to the back of the line in regard to this treatment?
Yeah, fortunately, those are mostly moot questions because we haven't had a reduction in supply. We tried to be very responsive when HHS signaled that we might have a shortage and already put those guidelines in motion, that they'll already have them once they have patients in front of them. Fortunately, as Brett was elucidating, the demand went down at the same time that this supply process changed, so we haven't had to enact that. Now, at the end of the day, every provider should always prioritize any medication for those at most risk. The only prohibition, absolute prohibition that we have and that any of our providers are following is that it cannot be used for post-exposure prophylaxis. So that basically is somebody is exposed, but they haven't tested positive yet. That is the only absolute prohibition, and hopefully, I'm optimistic that supply is going to hold and that we're not going to have to do any other prioritization for the foreseeable future.
Thank you.
Next question is for Kelly Roberts with WMC TV in Memphis. Kelly?
Hey there, thanks. So a couple questions just about vaccines. I guess just first about that booster. I know last week some public health officials in Memphis with some of our public sites kind of since that FDA approval came down, they said they were waiting for kind of final word and guidance from the state. I mean, at this point, can someone with those should and those may categories that you kind of laid out, I mean, can they show up and ask for that third shot, you know, if they have all that criteria right now, you know, here in Memphis in our public sites? And also, as some of these pandemic indicators have gone down, have you seen the vaccination rates kind of start to head back down as well? I know we saw an uptick during the large Delta surge.
Sure. Yeah, those are great questions. So as far as where you can get the booster shot, it is available and authorized anywhere in the state. I can't speak to individual providers' policies, but every provider has full permission from the state to use the CDC and the FDA's guidance, the ones that I've already gone through today, to give that booster to anybody who presents there. The state will not be issuing any specific guidance. We will just sort of parrot, for lack of a better word, what the CDC says. If there are providers, and I actually talked to some on Monday when I was in Memphis doing some site visits, who said that it might be helpful for the state to do that. So we're working on just sort of making this a little bit clearer because it's a lot of information for any of us to sort through. But there's not going to be any specific state guidance that differs from CDC or FDA. And your second question, I have forgotten. I should have answered it first. Go ahead.
It's okay. Basically, just seeing if you could just highlight kind of what vaccination rates look at this point. I know we did see an uptick during that large surge over the last couple months.
That's right. Yeah, that's a good question. We were looking at those numbers this morning. We have seen a decrease in vaccine uptake over the last couple of weeks, and that's pretty understandable. The surge is sort of on the downside now, and so are vaccines. I think, we had some really good uptake over the first few weeks of the surge, and so we'll see those people come back for second doses. And I will still see some continued momentum, but we are down from where we were the last 2 or 3 weeks.
Next question is to Blake Farmer. Blake?
I apologize because I try to only ask one question, but here's two. One is about the governor's executive order, which I believe is set to expire, the 5th of October, related to masks in schools. What has been your recommendation for what the governor should do sort of going forward as things change related to schools, COVID in schools?
You're smart to ask your questions one at a time. And so I'll take that one. Governor and I speak frequently about masks. He knows that from a medical standpoint, they are an effective tool. We also both recognize that there's not a lot of appetite for mandates, essentially none for government mandates. So I have no insight into how he's going to handle the upcoming expiration of the executive order, but it's clear, and he said it on multiple occasions, masks do work. And if you want to wear a mask, you should be able to wear a mask.
Okay. The other question is about mandates as well, but about vaccine mandates. I mean, if I understand correctly, we don't understand all of the mandates that are coming out from CMS, whether that's for nursing homes, but there are several entities that seem like they would fall under the requirements, such as the hospitals that haven't yet required vaccinations, which have more than 100 employees, nursing homes, probably other entities that you all, are the primary regulator of. So what is the health department's role going to be in enforcing federal vaccine requirements?
Yeah, that's a fair question. And you said something in that question that's really important is I don't know how that's all going to come out in the wash with all of the challenges to the federal mandates that have been announced, but we really don't have a ton of details yet on the actual rules of how those are to be implemented. Interestingly, the state doesn't have much of a role in determining that policy. I don't have to reiterate it again because I just said a minute ago how the governor feels about vaccine mandates. He's been very clear that vaccines are an incredibly important tool, but that it should be a personal choice. I'm worried about unintended consequences of these mandates as a condition of employment, particularly in areas that that are already short-staffed. That's not part of the state health department's purview. That is the federal government's purview. We do survey on behalf of the federal government, but we have to use their rules and survey by their standards. And so if and when that time comes, we'll execute our duties just as we're supposed to.
Well, sorry for one follow-up, and that is to put a fine point on it. Yeah, I mean, the CMS inspectors, at least from my experience, they essentially are Tennessee Health Department employees, right? Will you have them enforcing a vaccine mandate that comes from CMS? It would seem I'm hearing you sort of say yes, but maybe I don't know. Help me out.
No, the answer is yes. As state surveyors, we are a proxy for the federal government. So we just essentially are here on the ground and we survey on behalf of our federal partners. We don't get to make the rules or change the rules. So whatever the ultimate rules are from CMS, our state surveyors will have to survey on those standards.
Okay, thank you.
Next question is to Marta Aldrich with Chalkbeat. Marta? Marta, we can't hear you. You need to unmute your microphone.
Sorry, thank you. You mentioned the big development on the horizon is vaccine approval for school-aged children. You also mentioned that getting unvaccinated people vaccinated is the best way to end the pandemic. So what are the department's plans for promoting vaccine uptake for children ages 5 to 12?
Yeah.
Or 5 to 11?
Yeah, as a pediatrician, immunizations in children are top of mind for all of us, all of the time. And this one is really no different. It is a little different in so much as the severity of the disease, as you've heard us say many times, the severity of the disease is not generally as severe in children as it is in adults. But there are also other benefits of vaccinating children, reduced spread to other people who may be vulnerable. Even though vaccinated people can spread the disease, it is reduced. if you are immunized. And then likewise, there are other reasons for kids to be vaccinated other than to protect their health. It also exempts them from quarantine. It exempts them from some other, sometimes masking requirements, keeping them in the classroom, on the ball field, the places that the kids want to be. So the department will take an encouraging stance for childhood vaccines, just like we have for any other age group, and they'll be available at every health department just as soon as they're approved.
All right, last question is to Hannah Grabenstein. Hannah?
Good afternoon. My question is a monoclonal antibody clarification question. You answered my question earlier when you said that the only requirement was that providers not use monoclonal antibodies for post-exposure prophylaxis. Was that because of the NIH guidelines? Were providers were they distributing them for post-exposure prophylaxis prior to that? And then is the only thing keeping that post-exposure prophylaxis use the supply? Like when supply increases, should that should go into effect soon?
Yeah, that's a great question. So post-exposure prophylaxis wasn't a very common use to begin with. In fact, that indication or kind of accepted use only got added a few months ago. Really, as far as I'm aware, the only place that was happening was when a nursing home would have a large outbreak. And if there were close contacts of a case, they could give monoclonal antibody to those contacts to try to keep them from turning into a positive case. I have not seen any data on the effectiveness of that. And like I said, I don't think the use was very widespread to begin with. So it really hasn't been, there really hasn't been much pushback at all on that prohibition. And that prohibition specifically, as you mentioned, is part of the NIH guidelines, and it was all supply driven. And so, and you can, if you do one of these big outbreaks and give it to everybody that's exposed, that might be dozens of people in a particular area. Probably shouldn't be, but sometimes it is. And so while supply is still constrained, we don't have a shortage right yet, but while it's constrained, we're holding off on any post-exposure prophylaxis, but I don't think there was a big use case for that anyway.
All right, thank you, everyone. That concludes our briefing for today. We appreciate you joining us. If you have any follow-up questions, please feel free to reach out. Otherwise, we'll say good day.